I wanted to introduce Dr. Benjamin Schell. He's one of our fellows this year, and he's going to help us go through a lateral expandable cage. So we're going to go through the steps just from skin to skin and just put in one expandable cage. So Dr. Schell, why don't you show us the way?
So, not sure what you guys can see up on the x-rays or not. We kind of already found our level. We're going to try to go in from the left side. So I guess I'll orient you a little bit depending on which cameras you can see. Dr. Rowe and I are standing on the posterior side. So anterior is away from us. Cranial, you can kind of see that, yeah. Cranial up here, caudal. And then the x-ray, which may be showing up on one of these screens, we kind of already isolated our level at 3-4. There you go, right there on the left. So we've kind of isolated our level already at 3-4. And so we'll go ahead and make our skin incision kind of coming through. We've got a little bit of a emaciated patient, so there's not a lot of fat here, but then we'll pull the x-ray out, and there's a camera up north that will help us get a little bit better visualization.
Yeah, can you go back?
Yeah, just pull straight back would be great.
So typically after the skin incision, you know, we want to go through bluntly through the layers of the lateral abdominal wall. And usually we like to use 2 peons. So Dr. Schell and I are going to work together. We're going to go at right angles. I don't know if you guys can actually see the incision.
Oh,
there we go.
There,
yeah. So essentially, this is cranial. This is caudal again. This is dorsal. This is ventral. And you know, you're going to want to see the different layers of the musculature. The first is obviously the external oblique. So we're going to kind of go at right angles to each other. Can we get a little bit of light in there also? Yeah, no worries. So there's external oblique. And then after you get through each of the layers, you should see kind of a very fine, thin layer of a fascial. Okay, and so we're through the external oblique, so we're getting now into the internal oblique. And the internal oblique, you know, goes into the opposite direction of the external oblique. Okay, and it looks like we're through the internal oblique, and now we're getting to the transversus abdominis, and I think you just popped through the, right?
Yeah, felt like it.
So that sensation of actually going through and popping through that final transversus abdominis, or transversalis fascia, then what you want to do is then you want to put your finger down and sort of sweep the peritoneum anteriorly. And typically what I like to do is then feel for the crest here from inside of the pelvis. So you feel the inside of the pelvis, and then you follow that crest from lateral to medial. And then when you get down to sort of the mid aspect of the pelvis, that should be right around L5-S1, and then you should feel a transverse process there, right?
We're on it.
So then that's because of where we sort of centralize the lateral X-ray. We know that L5-S1 is going to be sort of in this direction, whereas typically in most patients, and you saw that this is like a perfect AP, the L3-4 disc space is going to be pretty straight up and down here. So then we know that if we go straight down from there, we should find psoas. Mm-hmm. And when you find psoas, typically that's when you want to just lay your finger on the psoas, and then we'll take the first dilator, and then we can put the dilator behind the finger there.
Yeah. So that you can kind of see that on the camera there. So my finger is right on the crest right there, mm-hmm. And then I'm sweeping it like he was just talking about from lateral coming around. And then my finger there is on a TP. And then my right anterior to my finger, right ventral to my finger is psoas.
So that TP that he's probably feeling should, in theory, be the L4 TP. And right above the L4 TP, meaning right cranial and slightly anterior to that, should be the disc base. So if you kind of slide that down right onto the psoas, we'll hold on to it. And the main importance of this part of the case is to make sure that you don't get any bowel contents within your path, within your approach. And some of the things to be aware of at L4-5, you're going to really start thinking about the lumbar plexus. When you get a little bit higher at around L1-2, L2-3, and you're gonna start thinking about the other anatomic structures such as the kidneys, and if you're on the right side, even the liver actually can come into play. Okay, so it looks like we're on here, so let's see where we're at.
Got it.
Okay, go and picture that. Okay, so it looks like from a cranial caudal perspective, we're a little caudal, but from an anterior to posterior perspective, we're pretty good, right? So all we're gonna do is we're gonna adjust this just up cranial just a hair, and I bet you anything, what's happening is we're probably riding on that disc a little bit. Picture that. There we go. We're a little bit anterior, so all I'm gonna do is just angle it just a little bit posterior. That's actually pretty good. Picture that.
Yeah.
And that should be pretty good, right? So we'll hold this and then go to a lateral. And if you have availability on the system, some systems allow you to actually stimulate at this point, you know? So I actually like to stimulate at this point before I penetrate the disc, because then I know whether or not there's actually lumbar plexus or exiting nerve roots at this level. So let's see where we're on a, okay, that's pretty good. We're a little bit cranial, so I'm gonna angle it caudal just a little bit. Picture that. There we go. So let's try that and see where we're at. So Dr. Shell's gonna advance this and see where we're at. So there's gonna be a hard endpoint, and then we're gonna need a mallet. Picture that. Picture that. Try that. It should advance, but it's a...
Yeah, it's going.
Picture. Okay, good. A little bit more. I like to get it right to the midpoint. Perfect. Okay. So now we're gonna expand and dilate over that.
Just as a added tip, when you get these wet, this is something that really helped me. It's a lot easier. You know, have the scrub tech, have the circulator, just kind of dip them in some saline, and then they slide over a lot easier. That may be a straightforward thing for guys who've been doing it, but as a new practitioner. You have another one?
I think this is it.
Oh, there we go.
All right,
Perfect.
so, yeah.
Yep.
There you go.
Shot there.
You don't have anything shorter than 150, do you?
10?
Yeah.
40?
Well, it's already set up, but this is a little bit on the long side. Why don't we? Yeah, let's just go for this. We can work around it. Okay.
And then that blue handle over there, okay, that's good. Flip it, sit down. No, you're right back. The bottom of it.
Okay. Okay, it's tight.
Yeah, 1 second. Okay. All right, shot there. Yeah.
Angle a little bit caudal. Picture. That'll be better. Okay.
Yeah, lock down. Sorry.
So we're slightly cranial at the cranial aspect. I think we're at the L3-4 disc space, so we're at the inferior margin of the L3 end plate, but that's okay. When we expand, we'll actually count for that. So why don't we take everything out?
Got a. Yep.
Hey, Jeff, while you're
Question?
Hey, Jeff, while you're setting up, just give us a quick overview of setting up the retractor. I know I've gotten into a little bit of trouble on the orientation and how you want it to be set up before you start the expansion.
Got it. So I think the most important thing is actually the alignment in the cranial caudal as well as the anterior posterior. At L3-4, I like it to be right central as much as possible. At L4-5, I like to be a little bit more anterior as much as possible. So we got this lateral view. We knew that we were starting the guide wire a little bit cranial. So, but we can work around that by how we place the blades. And then why don't we go for a true lateral? So the lateral will tell us where we are with respect to the anterior-posterior position. But that's a really good question, Amir. And you're exactly right. Like the positioning of the retractor will ultimately guide and dictate the positioning of the cage itself. So it looks like, can you cant it just a little bit towards the head? Oh, cant, not rainbow. So it looks like we're a little bit anterior.
Yep.
That might be too much. Picture that. Okay, that's decent. We are a little bit anterior. So what we'll do is we'll try to see if we can actually bring this posterior blade back towards us. Okay. So why don't do we have the adjuster for that? So why don't we bring this blade posterior so we can increase. We're anterior enough, but we want to get a little bit more posterior for sure. Yeah, as much as you possibly can. And then come on back in with a lateral. And you'll see that now we've expanded the window by which we can now work. Okay. See that? So it's still a little bit anterior, you know, see if you can actually even do it more, a little bit.
That's max.
Picture that. And then the other trick you can do is when you loosen that, I'm actually going to angle it posteriorly. You can loosen it.
Yep. Loose.
Okay, you can tighten that. And then can you rainbow it towards you about maybe 5 or 10 degrees? That's good. Thanks, Tyler. A little bit more. Picture that.
Hey, Jeff, this is Rod.
A little bit less. Hey, Rod.
I have a question for you.
Sure.
So can you talk a little bit about neuromonitoring and the
Yeah,
lumbar plexus?
absolutely.
Especially at L3-4 and L4-5.
No doubt. So for sure, I favor towards a neuromonitoring system that allows me to monitor at every point during the procedure, you know? So I typically like to use a neuromonitoring probe that also is protected, where the first step where we actually place the guide wire down even through the psoas, I'm actually monitoring it. And then when it's placed on the disc itself, I sort of think of it as sonar. And it really is sonar for surgeons who like to do both lateral and posterior surgery. So for me, I sort of, based on my position, I determine where the nerve might be. And so in a situation like this, what I'll do is, do we have a pen? I'll actually draw out quadrants. Can we see, can we picture right here? Is there, there we go, okay. So right here, essentially this is what we're gonna be looking at. We're gonna be looking at this, and I'm gonna draw a circle. We're actually, it's a little bit more of an oval because we've expanded it. But essentially, this is cranial, this is caudal, this is posterior, this is anterior. Essentially, what I do is I put a neuromonitoring probe there, and there, and then I'll get 4 readings, and then I'll also do one right there. And typically, at say for instance at L4-5, where there's the highest chance of actually getting into a nerve injury, you'll get a reading maybe like 2, 5, 10, and 10. In that case, I know that there's a nerve here, you know, and so I'll actually look for the nerve. And so we don't have a microscope here, but I use a microscope for every single case. I go in there, and then I'll actually kind of start gently, exposing the disc space, and then I'll expect that a nerve is going to be here. And sometimes I'll even, avoid actually being right here. So essentially, that's sort of the best way of determining where the nerve might be. I treat lateral cases just like posterior cases, like a T-lift. Because in a T-lift, we know that when we go into Camden's triangle, we expect the exiting nerve root, right, to be sort of at the upper outer quadrant, and we expect the traversing nerve root to be at the medial aspect of our working portal. Same thing with here. Mm-hmm. At L3-4, typically, you're going to see, in the majority of cases, most of the neural activity occurring in the posterior 2 quadrants. So by doing this, you can get a much better idea of where the nerves might be. So not only will I use neuromonitoring, but I'll use direct visualization through a microscope to make sure that there are no nerves in the way. If we do find a nerve, say for instance, we see a nerve that traverses out like this, right in our field. And this is the disc space, okay? So that's the disc space. And if we see a nerve that does this, it's just like any other spine case. We go in there with a retractor, and we retract it out here, typically with a love nerve retractor, you know? And these type of retractors allow for us to actually kind of work around the blades. And then after we do the discectomy and disc preparation, then we just let the nerve kind of fall back to where it once was. Does that answer the question, Rod?
Yes, thank you.
Yeah, no problem at all. So we have a light source in there now, and so let's see what it looks like. Okay, so why don't we get it? And normally what we would do, let's get a pituitary, because we're seeing some muscle, but what we would do is we'd look in there and feather away the muscles overlying the disc base. Oh, that's a pretty good view, actually. Can you focus that?
Yeah, he's going to manually set the camera so it doesn't keep...
Got it, okay. So there's there will always be a nice thin layer of the psoas overlying the disc base, but what I'll do is I'll take a bipolar and then kind of feather over the muscle longitudinally to allow the muscular layer to kind of like to expose the disc base naturally. And then when you run into nerve, you'll see it. I mean, we're all spine surgeons, right? So when you see nerve, you can recognize it. How's it looking?
Just going to expand it a little.
Got it.
Caudally to...
Okay. No, that looks pretty good, actually.
Yeah, that's a good view.
Yep, that's
Nice
a great
work,
view.
Tyler. Thanks.
I'm pretty impressed with the... It's not even a microscope, it's a camera. It looks like it's a scope.
We should start using that.
Yeah. So Ben's gonna sort of expose the disc. And that's just the psoas muscle right there. And typically, I won't even do this step unless I know that there's very little neural activity, and I'm doing all of this under microscope. So Ben and I would be doing this, watching it together, but it looks pretty good, you know? Great. Okay, so why don't we do the discectomy? So we also like to use these sort of annulotomy knives that sort of retract in and out. So why don't you go to a lateral now? And let's see where we're at with respect to the craniocaudal. And it looks like based on our last x-ray on the lateral view, if we stay within the central portion of that, of our working space, we should be able to position our interbody spacer right in the middle of it.
Okay.
Okay.
Oh, it's better if I bring it up? Oh, sorry.
So why don't you just position it right where you think the midpoint of the disc might be, and then we'll get a shot. Picture that.
Even more
That looks
caudal.
great. No, that looks good. I think maybe a millimeter caudal, and then I think that it's going to
Try
be
that?
perfect. Yep, I would advance that and then do a wide annulotomy. And essentially what Ben's going to do is he's going to make an annulotomy, but then he's going to find and feel the inferior end plate of L3 and then kind of cut along that end plate. So it's going to look like more of a convexity there. And then he's going to sort of do the same thing and feel for the superior end plate of L4 and do the same thing, and then connect those two at the anterior and posterior aspects. And then take a flap of that annulus, and that's sort of the best way of doing a full annulotomy, if that makes sense. How's it looking, Ben?
Oh, we're good. Trying to get a big chunk of this out.
We got a question from the chat that's an interesting one, and I know this is kind of a moving target and maybe different for different levels. But looking at traction neuropraxia, I know that we look at the retraction time very closely when we're doing these cases. Do you guys use any different amount of time for different levels, or is it kind of across the board? You have a limitation on how much time you'll keep that retractor open before you take it down?
You know, this is my personal opinion, but I don't think it's just the pure retractor time. I think it's the amount of time that the nerve gets retracted, right? So just like you sort of keep an eye out on the retraction time for an ACDF, for the esophagus, and the trachea, for that matter. I think the same thing holds true for this type of procedure. I mean, it would be like if you're doing a T-lift and you're just like really retracting the exiting nerve root for the entire case, that patient's gonna have some sort of neuropraxia. And it's no different here outside of the spinal canal. So I think that in general terms, it's better if you minimize the retraction time, but more so than that for me is whether or not I know that a nerve is literally being retracted here. But in general terms, yes, it's true. The shorter the time of retraction, the better it is for the patient. I almost like categorically tell my patients now, you're gonna feel some numbness in the anterior aspect of your anterior thigh and maybe even your groin. And you're just expect that you're gonna have some weakness when you flex your hip and maybe even when you extend your knee, because of the fact that this is a physical sort of iatrogenic phenomena where we're literally putting a retractor into somebody's psoas muscle, which most of you know is a filet mignon, right? So it allows us to flex our hips. And so people are naturally gonna feel some weakness. And I think that people, patients typically that tend to have smaller psoas is like, I feel that like elderly women typically tend to have this phenomenon more so than other patient populations. But I just categorically tell patients that they're gonna feel some numbness and tingling in the anterior aspect of their thighs now. Okay, can we get a cob? Okay. Do you think this will fit down there, Ben?
Yeah.
So the cob, we're gonna a cob is sort of a feel type of instrument where essentially Ben's gonna put it into the end plate and kind of slide down that end plate. Picture that? Good. And then you could also use a mallet too. Do we have a mallet? And we can sort of assist this. I'll kind of gently, and you kind of guide it. We don't want to go into the end plate. Picture that? Okay, and so keep on, keep it close to that. Picture. 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 And then when we're here, we're gonna pop through just a little bit. Picture. Picture. Okay, we're popped through. And then here, kind of want to wiggle it just a bit, just to open up that other side.
Okay.
And then we're gonna do the superior end plate of L4. You know, so for normal cases, and it depends on the type of cage. If it's a type of cage that rests on the apophysis, then I'll do this almost every single time. The only exception would be, picture that. Like, this is pretty good. Picture. Yep. Bring your hand. Just picture. That looks pretty good. Picture. The only exception would be is I like to approach deformities on the concavity of a curve because that's where it's compressed and you actually want to expand that. You want to release what's tight and maintain what's loose. So typically I don't like to violate the convexity because you want to keep that intact. So I'll release all of the concave annulus, and if they have any bone on bone, I'll use an osteotome to open that up. That would be the only exception, but otherwise, like releasing the contralateral side, especially cages that are meant to sit on the apophysis, I'll do that. For the newer type of expandable cages that are meant to sit within the disc space, the nuclear core of the disc space itself, I won't do that. All I'll do is I'll just prepare the inside of the disc space and maybe just release the contralateral aspect just a little bit. How's it feeling? Can we get it shavers next? Let's start. Yes. Okay. We're almost We're almost ready for the cage. We're getting a time check here from Tyler. Thank you
Shot.
for keeping us on track. Okay, let's shave that. And what size does this cage go from? From where to what?
7 to 14 and 17.
Okay. We'll use the maximum 14 one.
Great.
Yep.
Shot there.
Neck shaver. Is this the trial? Okay. So let's put this in for the trial. Let's give him a trial size as far as the length goes.
Mallet.
A little bit more. Okay. Let's go one less. 55. That looks good. Back slap. There you go. Okay. Thanks.
Shot there. Ooh, shot there.
So that's a picture you don't want to see,
Yeah.
right? I mean, in general, but especially at
Shot there.
4-5, you can actually injure the contralateral lumbar plexus. Okay. And then come up just a little bit, maybe a centimeter, picture that. And then just a little bit more. Let's do it on this side of the end plate as well. Picture? Good. Okay. And then pituitary. Let's clean out the rest of the discs, and then we'll put in the cage. I think we'll go with 18.
Another question from the chat box. I know there's some variety out there in practitioners. Do you prefer to stand always posterior, or is there a reason that you would come anterior to the patient?
That's a great question. Typically, if it's a little bit more of a lateral lumbar interbody, pure lateral approach, then posterior. If it's a little bit more of an oblique, then more anterior. But I don't think it really matters. I think it's just kind of preference, to tell you quite honestly. So it doesn't really matter whether it's anterior or posterior. The only thing to be aware of is if you're posterior, the chances of you going more anteriorly is higher because you're working from posterior to anterior. And if so meaning that you got to be aware of the contralateral side, including the peritoneal contents, including the when you're up a little bit higher, the aorta, the IVC. If you're down by 4-5, perhaps you're thinking about the iliacs as well. If you're more anterior, then you're worried about more of the posterior elements, including the spinal canal and the neural elements. Picture? Okay, a little bit more. A little bit more. A little bit more. That looks pretty good. Picture? Okay, why don't we get a lateral just for S and giggles?
Yeah, you're good.
Let's see how good you were.
It was quick. It's the fastest I've ever done one.
This should be about 30 minutes. Can you rainbow over towards us? Yeah, towards you. Sorry, towards you. Yeah, picture that. That looks pretty good. I like that. Okay. Save that, go to lateral. I think you're good, so we're gonna expand this mofo. Okay, let's start with the lateral and then watch it expand.
Oh yeah.
Okay. Oh. Yeah. And this is not a perfect lateral either. The rotation's a little bit off, but I don't know if we can rotate the bed at all. Okay, no worries. Okay, go ahead and start
You got that
expanding,
one?
doctor.
Left to right, that one.
Picture.
Just so that we can kind of compare and contrast.
Oh, doctor. it clicks, right?
So what's the range in the cage that you guys are using there?
7 to 14. The other option's 10 to 17. Picture that. There we go. There we go. There
it
we
is.
go. The click. 3 clicks. One more. There we
get the
go.
money
That's
worth.
good. Picture that. Awesome. That looks great. Okay. And then you unscrew that, the gold. I think they're telling us we have to. Okay, picture that. Save that, go to lateral. This is it. Judgment day, graduation, final exam.
Just don't record it.
Oh, doctor! Nice job.
Done. Yeah, exactly.
All right, sounds good. We're off.
Go ahead and take the retractor out so we get a nice view. 'Cause
Okay,
that's
sounds
a
good.
really nice
We'll
placement.
do, we'll do. I mean, just to be, if we're sort of judging ourselves, it's a little bit on the anterior side, which is okay. I'd rather be a little bit anterior than posterior. So let's take a look at the lateral again. And it depends on what you're trying to accomplish, right? Like if you go more anterior, I think you're using the sort of the ligament ataxis of the ALL. Now I'm pretty happy with that, But with that being said, if you're trying to increase the intervertebral disc space and increase the size of the foramen, then it's better to be a little bit more posterior. So it really depends on what you're trying to accomplish, But I think that if you're trying to accomplish more lordosis, you want to be a little bit more anterior. If you want to try to accomplish increasing the craniocaudal dimensions of the foramen, then you want to be a little bit more posterior. But I'm very happy with that. I think that looks great, especially in a patient with flat back. This is how I would want to position it. So nice work, Ben.